Now, we will just take one question of Jacob and then we'll move on to the chronic renal failure. So what Jacob is asking is his question is mainly about the urine creatinine to the serum creatinine ratio. That is what is his concern. Right. So in case of pre-renal, the organ perfusion is reduced, and there can be reduced perfusion even to the muscle as well, and that is causing the muscle injury. And because of the muscle injury, there is increase in the serum creatinine, right? And the serum creatinine which is elevated is very, very high then compared to normal. Okay. Now, Jacob, tell me, in case of kidney injury, is the in case of pre-renal, is the renal perfusion completely zero? Yes, Jacob, are you there? Yeah. So, in case of pre-renal, renal perfusion, it is present, but reduced. Okay, but reduced. Okay, but in the plasma of pre-renal patients, what has happened to the serum creatinine value? Grossly increased. Now, because of this renal perfusion, which is being present, but it is just reduced, that's all. It is not completely zero or it is not completely absent. So now tell me, Jacob, the amount of creatinine which is going to the kidney in case of pre-renal because of the muscle injury, is it normal quantity of the creatinine going, or is it increased quantity of the creatinine going to the kidney? Is it normal quantity of the creatinine which is going to the kidney, or is it increased quantity of the creatinine which is going to the kidney? Right? So definitely you will have increased quantity of the creatinine that will be going to the kidney. Okay? Even though the perfusion is reduced, within that perfusion, whichever is going to the kidney, through that perfusion, excess amount of creatinine is going to the kidney. When excess amount of creatinine is going to the kidney, what will happen to the urinary excretion of creatinine, Jacob? What will happen to the urinary excretion of the creatinine? Is it normal or is it increased? It is also increased. So, what we consider is the urinary creatinine is elevated. And where is that urinary creatinine coming from? It is coming from serum or it is coming from the plasma. So, you take the urine creatinine to the plasma creatinine value, it is more than 40. Okay. Did you understand this, Jacob? Right? Your doubt is actually good. You are under the process of thinking that, sir, plasma creatinine is also elevated. So the value should get normalized. I mean, the value should be equivalent to 1. But the point here you should understand is that the amount of the creatinine which is going to the kidney is more than compared to that of normal. So urinary creatinine is also elevated, and it is elevated much more than that of the plasma creatinine. That is the reason why the urine creatinine is ratio to the plasma creatinine is more than 40. Actually, if you ask me, in both urine also the creatinine is elevated, the serum also the creatinine is elevated. But the point here what you should understand is the urine creatinine is much more elevated than compared to that of the serum creatinine. Okay, that is what is the concept you should understand here, right? So I hope I'm clear to you. No, sepsis Sepsis will cause vasoconstriction. Yes, Hari. There will be renal artery vasoconstriction. Yeah, yes. Kamalanathan is adding to the explanation. That's also a valid point, right? What he says is the plasma creatinine concentration is diluted as well. Why the concentration is diluted? Because there is a fluid overload. So definitely the denominator value reduces, right? And the numerator value is increasing. Okay, right. So that was about the story of urine creatinine to plasma creatinine. Now, after having discussed about the acute, so how is the session going on? So are you comfortable in understanding? Is it fast? Is it slow? Do you want me to increase the speed? You want me to decrease the speed? Or is it fine? So how do you feel the session is going on? If you can give me a quick reply, so that helps me in progressing with the remaining part of the session. In case of the chronic renal failure, right? In case of the chronic renal failure, it is the GFR which is added to the definition. In case of acute renal failure, according to your KDIGO guidelines, GFR is not the component. But here, in chronic renal failure, according to the KDIGO guidelines, GFR is added to the component. Okay, so now let me take up the discussion of chronic renal failure. So before that, can anyone tell me quickly how much is the normal GFR? Anyone of you, please? How much is the normal GFR? Right. So the correct answer is from Vaishnavi Gupta, right? That is 90 to 125. So it is not exactly the cutoff value, right? Exactly like 120 or 125. You don't have a straight cutoff value. It's a range. And that particular range, it is around 90 to 125 ml per minute per 1.73 meter square. That is what is the normal GFR. Okay. So if you take the discussion of chronic renal failure, what is the definition of it? It is defined as decrease in the GFR. How much should be that decrease in the GFR? Less than 60 ml per minute per 1.73 meter square. That is a GFR. Along with decrease in GFR, there should be also proteinuria. And for how long this should be? That is decrease in GFR less than 60 ml per minute per 1.73 meter square. And along with that proteinuria, this should be there for more than 3 months. Right? This entire story should be there for more than 3 months. And the normal GFR, if you just check, it is around 90 to 120 ml per minute per 1.73 meter square. That is a normal GFR. And this definition of chronic renal failure is given by KDIGO guidelines. Right, given by the KDIGO guidelines. Now, based on the quantity of decrease in the GFR, we classify the chronic kidney disease into stage 1, stage 2, stage 3, stage 4, and stage 5. Now, What are these particular stages? Let me take a. So if you see the stages of CKD, so stages, how much will be the GFR? In stage 1, the GFR is normal, but there is kidney damage. And how much will be the GFR? More than 90 ml per minute per 1.73 meter square. So what is that you are observing here? You are observing that there is a kidney damage, right? There is a kidney damage with normal GFR, right? With normal GFR. So that is stage 1 description. Then stage 2 is that the GFR is reduced. It is reduced by almost 30 times. How much? That is 60 to 89 ml per minute per 1.73 meter square. And here there is kidney damage and there is mild or mildly decreased glomerular filtration rate. That is your stage 2. Okay. So in stage 1 and stage 2, the actions that you have to take is you have to diagnose chronic renal failure. You need to treat the underlying etiology, treat the comorbid condition, estimate the risk of progression of the chronic renal failure, slow the progression, and cardiovascular disease risk has to be reduced. Okay, cardiovascular disease risk reduction should be there. That is in stage 1 and stage 2. Now, whereas stage 3, if you take, it is again subdivided into 3A and as well as 3B. It is divided into 3A and 3B. So in 3A, reduce the GFR by 15, and 3B again reduce the GFR by 15. So how much is that in 3A? In 3A, GFR is around 45 to 59 ml per minute per 1.73 meter square. Okay, so here you are observing that there is mild to moderate decrease in the GFR. Okay, whereas in 3B, again you reduce it by 15. So how much that will be? That is around 30 to 44 ml per minute per 1.73 meter square. So here you are observing that there is moderate to severe decrease in the GFR. Right, moderate to severe decrease in the GFR. Then we have stage 4. Stage 4 is that the GFR will be 15 to 29 ml per minute per 1.73 meter square. And in stage 4, you will notice that there is severely decreased glomerular filtration rate. And what is stage 5? Stage 5, the GFR is less than 15 ml per minute per 1.73 meter square. And this stage 5 is considered as end stage renal disease. Right? It is end stage renal disease. And these patients in stage 5, we classify them into 5D, where they require dialysis. And we classify them into 5T, right, where the patient have undergone transplantation. So this is about your stages of the CKD: 1, 2, 3, 4, and as well as 5. So in every stage, in 1, 2, 3, reduce it by 30 and 30, but only in 3, 15 and 15. And again from stage 3 to stage 4, reduce it by 15, and in stage 5, less than 15. Now, very important is you should identify what is the underlying etiology, and you have to prevent the progression. That is a very, very important part of the treatment, because in stage 5, even the dialysis technician also will tell that you require dialysis. That's not a big thing, but your target should be identify the patient in stage 1 and stage 2 and prevent the progressions to stage 4 and stage 5. That is what is the ideal treatment. That is what is the ideal treatment. Now, that is about the GFR. And we have discussed that there is also proteinuria in the chronic kidney disease along with the decrease in the GFR. Now, based on the proteinuria, how much is the normal albuminuria we have discussed? Yes, normal albuminuria. Quickly, please. Right. So that is 30 milligrams per 24 hours or less than 30 milligrams per gram of creatinine excretion. Okay. So based on the proteinuria, the CKD patients, they're being classified as A1, A2, and as well as A3. So A1 is that where there is, right, where there is normal or mild or mildly increased albumin levels. Okay, mildly increased albumin levels. That is what is your A1. So how much will be that? That is less than 30 milligrams per grams of the creatinine excretion. That is what is your A1. So whereas A2, if you observe, it is moderately increased albumin excretion. And how much will be that? 30 to 300 milligrams per grams of the creatinine excretion. So this is like in the spot urine sample, and this we call it as the albumin excretion rate. This we call it as the albumin excretion rate. Okay. Whereas you take A3. A3 is that it is severely increased albuminuria. Right? Severely increased albuminuria. Severely increased albuminuria is that where the proteinuria will be more than 300 milligrams per grams of the creatinine excretion. Okay. So that is about the classification of your acute renal failure based on GFR, that is stage 1, 2, 3, 4, 5, or we call it as grade 1, grade 2, grade 3A, grade 3B, grade 4, and grade 5. Okay, the same staging, we can consider it as grade 1, grade 2, grade 3A, grade 3B, grade 4, and then grade 5. Then albumin excretion, based on quantity of the albumin excretion, we classify them into A1, A2, and as well as A3. Now, so we have discussed that there are 5 grades. So out of which you need to know a terminology called uremia, and you need to know a terminology called azotemia. So grades 1, 2, 3, 4, and 5. So grade 1 to 4, these patients, they are asymptomatic. Right? They are considered to be having azotemia. Whereas grade 5, they become symptomatic. Right? And this we consider it as uremia. This we consider it as uremia. Now, what is azotemia? There is increase in urea and creatinine. Right? There is increase in urea and creatinine, but asymptomatic. Whereas in case of stage 5, there is increase in urea and serum creatinine, and at the same time, the individual is symptomatic. That is called uremia. So, if in spite of increase in urea and creatinine, if the individual is asymptomatic, that is called azotemia. In spite of increase in urea and creatinine, if the individual is symptomatic, then we consider it as uremia. Now, what are the etiologies that will be responsible for your chronic renal failure? So, most common cause. Does anyone know what is the most common cause of chronic renal failure? Anyone? Very good, Vinita. That is diabetes mellitus. Okay. So, most common cause for chronic renal failure will be diabetes mellitus. Then, apart from diabetes mellitus, right, we have many other conditions which will be causing the chronic renal failure. Right. So, if you take the various etiologies, that includes number 1, glomerular diseases. Right. Then we have tubulointerstitial pathologies. Right, tubulointerstitial diseases. Then we have cystic diseases. Then we have obstructive nephropathies. And lastly, we have vascular diseases. Okay. Now, you take the glomerular causes. The glomerular causes, like we have primary glomerular conditions, and then you have secondary glomerular diseases as well. Right? Primary and secondary glomerular diseases. The primary glomerular diseases that includes focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, then IgA nephropathy, then membranous nephropathy. So these are the causes, these are the primary glomerular diseases which will be responsible for chronic renal failure. Then what are the secondary causes? Secondary causes include diabetes mellitus. Then we have renal amyloidosis. Then secondary to immune complex deposition within the kidney, that is post-streptococcal glomerulonephritis. Then HIV associated nephropathy. Then connective tissue disorders or collagen vascular diseases, that is systemic lupus erythematosus. So these are secondary glomerular diseases, right? We have primary and then secondary. And in primary, we have one more inherited condition, that is Alport syndrome, right? So it is an inherited condition which is a primary glomerular pathology. And what will be that pathology? We will be discussing that. So these are the glomerular diseases which will cause chronic renal failure. Whereas tubulointerstitial nephritis, they are mainly drugs, right? And what are those? We will discuss tubulointerstitial diseases. The tubulointerstitial diseases include heavy metal intoxication, then followed by that analgesic nephropathy. And what will be that analgesic nephropathy? NSAIDs, non-steroidal anti-inflammatory drugs. And we were discussing the important etiology which was causing clumping. That is a vascular disease and a hematological disease, that is sickle cell. Right? Sickle cell nephropathy is also one of the condition which will cause problem in the tubules and interstitium, causing chronic renal failure. Okay. And lastly, the chronic pyelonephritis. Right? So these are the tubulointerstitial diseases. Now, we have done with the glomerular pathologies, and then the tubulointerstitial diseases, what are all those various conditions. Then followed by that cystic diseases. If you take the cystic diseases, that includes polycystic kidney disease, then medullary cystic diseases, right? So these are the cystic diseases that will contribute to the development of the chronic renal failure. Then we have obstructive nephropathies. Remember, these obstructive nephropathies, it can cause post-renal type of acute renal failure. But if these post-renal type of acute renal failure are not being treated for a longer time, then that acute will progress to chronic. Acute will progress to chronic. So what are those obstructive nephropathies? The obstructive nephropathies, if you observe, that includes benign prostatic hyperplasia, that is BPH, or prostatic disease. Then stones, that is your ureteric stones and all, as we have discussed in postrenal also. That is nephrolithiasis. Then retroperitoneal fibrosis. This retroperitoneal fibrosis, how it will cause obstructive nephropathy? This retroperitoneal fibrosis can cause obstruction to the ureter. That can lead to the obstructive nephropathy. And what are the vascular diseases? Vascular diseases, they include renal artery stenosis, then hypertensive nephrosclerosis, right? Hypertension. So these are all the conditions which will be causing the chronic kidney disease. So how did we classify the acute? We classified the etiologies causing acute into pre-renal, right, intrinsic renal, and post-renal. And how are we classifying this? Glomerular pathologies, tubulointerstitial pathologies, cystic, obstructive, and then vascular. Okay, but among all these, the one which is more common is the diabetes mellitus. That is the most common cause. Right? Now, after having discussed about the etiology, you need to know the clinical features. The clinical features will be what? The clinical features will be similar to that, like what we have discussed in acute, but there are some add-on features. There will be few or some add-on features that will be there. Okay. So the clinical features, if you observe, you will have the clinical features due to right. You will have the clinical features due to fluid overload because the urine output is reduced, right? And what will be that? Same. That is periorbital edema, pericardial effusion, pleural effusion, ascites, and pedal edema. Same. And they will also have features because of increase in the urea levels. That is uremic encephalopathy, uremic pericarditis, uremic gastroparesis, and urea accumulation within the skin, where there will be dryness or xerosis of the skin. Okay. And the another important is there will be decreased urine output. That is, they will have oliguria and as well as the anuria. I have discussed. So these three, that is clinical features due to fluid overload, decrease in urine output, and clinical features due to increase in urea levels. These three we have discussed in the acute also. But in chronic, what are the additional points now? The additional points is that, so in patients with chronic renal failure, what will happen to the calcium levels? The calcium levels decreases. There will be hypocalcemia. Why is that? What is the reason for hypocalcemia in chronic? In acute, I said there will be calcium phosphate formation, thereby the calcium level reduces. But in chronic, why is that you have hypocalcemia? Anyone? Very good, Niveta. That is vitamin D deficiency. Niveta, can you tell me what is the enzyme in the kidney that is required for the formation of active form of vitamin D? Anyone? What is the enzyme required for the formation of active form of vitamin D within the kidney? Right, very good, Rohita. So that is 1-alpha hydroxylase. It is your 1-alpha hydroxylase, which is like formed in the proximal convoluted tubule. Okay. Right. So because of your kidney damage, 1-alpha hydroxylase is not formed, and thereby there is hypocalcemia. So because of the hypocalcemia, what will be the features? Once there is hypocalcemia, what you have to remember and understand is that, right, what you have to remember and understand is that there will be excessive release of hormones. Can anyone tell me what is a hormone that is released in excess quantity in response to your hypocalcemia? Very good, Jacob. So there will be excessive release of parathormone. And this we call it as secondary hyperparathyroidism. And once there is secondary hyperparathyroidism, what will happen to the bone? There is increased resorption of the bone. So thereby, what will happen to the bone mineral density? Bone mineral density will be reduced, and that we call it as osteoporosis. But this particular osteoporosis is secondary to what? This osteoporosis is secondary to renal damage. That is the reason why this is considered to be, or this is called as renal osteodystrophy. right? That is why this is called as renal osteodystrophy. Okay, so what is this renal osteodystrophy? Renal osteodystrophy is that where there is decrease in the bone density secondary to increase in parathormone levels and secondary to hypocalcemia of vitamin D deficiency. And these particular bones, they are at increased risk of fractures, that is pathological fractures will be there. Now because there is vitamin D deficiency, there is hypocalcemia. So because of your hypocalcemia or renal osteodystrophy, what will happen to the growth of the individual? There is growth retardation. And this growth retardation, it is due to two reasons. One is because of decrease in calcium levels, and other reason is in patients with chronic renal failure, in all cases, there will be anemia due to erythropoietin deficiency, right? Due to erythropoietin deficiency, there will be anemia, and that will contribute to the development of your growth retardation. Okay, now that was about the growth. Next, and another reason why there is growth retardation is these patients will also develop metabolic acidosis. And what are all the various reasons of metabolic acidosis? It's a very, very important multiple choice question. Metabolic acidosis is not just only because of impaired bicarbonate reabsorption. In these individuals with chronic renal failure, the metabolic acidosis is due to the following reasons. Number one, decreased ammonia synthesis. Right, decreased ammonia synthesis in case of chronic renal failure. Now, what is the problem? If there is decreased ammonia synthesis, why there should be acidosis? Remember, ammonia is one of the very, very important substance which will take out the H plus which is formed in the body. The H plus which is formed in the body, it will combine with ammonia to form ammonium, and ammonium is excreted out. Okay, and there is decreased ammonia synthesis. So the H plus will not be excreted and that will remain in the body. And the next important is impaired bicarbonate reabsorption. Right, impaired bicarbonate reabsorption. Okay, at the level of your PCT, the bicarbonate has to be absorbed, and there is impaired bicarbonate reabsorption, and that will result in the acidosis. That will result in metabolic. So due to decreased ammonia synthesis and impaired bicarbonate reabsorption, there is acidosis in the individual. Now, next to these features, these patients, they will also have abnormal blood related parameters. What will be that? Let me try to explain to you. So first, these patients, they will develop anemia. So why is that there is development of anemia? The anemia is because of decreased erythropoietin production, right? The peritubular cells in the kidney will form erythropoietin. And when the kidney is damaged, erythropoietin production reduces. And that will result in anemia. And the type of anemia that the individual will develop is normochromic, normocytic anemia. Right? Normochromic, normocytic type of anemia. Now, the anemia could be due to multiple other reasons also. What could be the other reasons? That is add-on. What will be that add-on? Because of the uremic gastroparesis, you see here, I said you because of increase in urea, there can be, see, I have just written here as increased urea. But in your notes, you have to write there can be uremic encephalopathy, uremic pericarditis, uremic gastroparesis, and xerosis of the skin. And when there is uremic gastroparesis, what will happen to the absorption of your vitamins and minerals? Reduces. So there can be vitamin B12 deficiency, there can be iron deficiency also. So that is the reason why these individuals, they will have any form of anemia can be there, but predominantly normocytic normochromic, that is mainly because of your erythropoietin deficiency. All right. Then these patients, they also have decreased granulocyte function. And why is this decreased granulocyte function? Multiple reasons. One is because of decrease in erythropoietin, right? The bone marrow is not activated properly. And second is urea goes and accumulates even within the bone marrow when there is excessive increase in urea. And that will cause defective granulocyte formation. So once there is defective granulocyte formation, these individuals, they are at increased risk of infections. Right, these individuals, they are at increased risk of the infections. And next important is these patients, they also have defective platelet function. Same reason again, the erythropoietin is not there in adequate quantity. Even the platelets function also becomes defective. That is the reason why these patients, they have increased bleeding tendency. And if you observe the skin of these individuals, you will notice that there is petechiae and ecchymosis. Right, there is petechiae and as well as ecchymosis. And there is also excoriations. Right, so excoriation in the sense like where you have the skin being like having that bleeding tendencies, you will have that multiple cuts over the skin. That is about your blood parameters. Then you take the individual organs, what will be their status in chronic renal failure. Individual organs, you take the cardiovascular system. Already we have discussed that these patients will develop uremic pericarditis. And not only that, because of the fluid overload, they will have hypertension. And because of uremia into the pericardium, there is uremic pericarditis, because of which the patient can develop chest pain. And not only that, these patients will also develop cardiomyopathies. Okay. Now, these patients, because as we have discussed cardiology, can you tell me what type of pericarditis these patients will develop? I think I have taught you the cardiology. I think you have attended online. Can anyone tell me what type of pericarditis you will have in chronic renal failure? Yes. What type of chronic renal failure? Sorry, what type of pericarditis? No, not dilated. Pericarditis. I'm asking what type of pericarditis? Jacob, what is the form of pericarditis where you have pericardium being completely calcified? And tuberculosis is the most common cause. Very good, Soumya. Excellent. That is constrictive pericarditis. So the type of pericarditis what you will have in these individuals with the chronic renal failure is the constrictive pericarditis. Soumya, like in constrictive pericarditis, what is the important auscultatory finding? What is the important auscultatory finding in constrictive pericarditis? Any one of you? Very good, Jacob. That is the presence of pericardial knock. Pericardial knock. So can anyone tell me what is the important cardiac catheterization finding, or what will be the ventricular pressure changes in constrictive pericarditis? I have said you one important sign. What is a very important sign? The very important sign in patients with a constrictive pericarditis on the cardiac catheterization is? None of you? Square root sign. Square root sign. Right? And Soumya, can you tell me what is the most common cause of constrictive pericarditis? What is the most common cause of constrictive pericarditis? Very good, Soumya. So that is tuberculosis. Tuberculosis is the most common cause. And the presentation of these patients with the constrictive pericarditis is dyspnea. And they will also have palpitations. That is because of development of atrial fibrillation. And on examination, they can have hypotension, they can have tachycardia, and on auscultation, you will have pericardial knock. And the 2D echo, it will show septal bounce, low voltage complexes. Cardiac catheterization will show the square root sign. And regarding the treatment, you need to give the diuretics, but you need to give diuretics very cautiously because already there is hypotension. And the other say, if the individual is like, we need to do pericardiectomy. That is what we have discussed regarding the constrictive pericarditis. The other organs are CNS involvement or neurological involvement. So neurological involvement, already we have discussed that there will be uremic encephalopathy. Okay, uremic encephalopathy. Then another important neurological manifestation is, along with the urea accumulating in the brain, urea will also accumulate in the peripheral nervous system, resulting in peripheral neuropathy. Right, resulting in peripheral neuropathy. That will be the neurological manifestation. Then followed by that, dyslipidemias. These patients with chronic renal failure, they will have hyperlipidemia. And why they will have hyperlipidemia? Because in chronic renal failure, there is decreased lipoprotein lipase activity. Right, there is decreased lipoprotein lipase activity. That will result in the dyslipidemia or the hyperlipidemia in these patients. And finally, the genitourinary manifestations. The genitourinary manifestations in these patients will be in the form of impotency. And I was also discussing about isostenuria. What do you mean by the word isostenuria? Right? What do you mean by this word isostenuria? Just now we were discussing isostenuria, right? What is isostenuria? Isostenuria is that where the specific gravity of the, specific gravity of the urine will be similar to that of the specific gravity of the plasma. That is what is called isostenuria. Okay, right. So this was about all the manifestations in chronic renal failure. Now you need to know differences between acute kidney injury and the chronic kidney disease or chronic renal failure. Okay, you have the antecedent or the past history of renal disease. You will have the past history of renal disease in the chronic renal failure, but not in the acute kidney injury. And at the same time, in which condition you have sustained elevation of the serum creatinine. Right, sustained elevation of serum creatinine for more than 3 months. Right, so you have that in case of chronic renal failure, but not in acute renal failure. Okay, then what are the conditions where you have the presence of anemia? It is very rare in acute, but present in chronic. So in acute, what is the reason for the anemia? The reason for anemia in acute is if the hemolytic anemia, right? If the hemolytic anemia is the cause for the acute kidney injury, then in such case, you will have the presence of the anemia. Then elevated levels of the electrolytes, right? That is elevated serum phosphate levels, right? Decreased calcium levels, right? Elevated parathormone. So all that, they're significantly present in chronic, right? But in early phase of acute, these might be absent, but later they can be, but in early phase of acute, these are absent. Next is development of neuropathy. So what is the condition where you have the presence of neuropathy? It is in chronic. And why is that? That is because of uremia. And the amount of uremia and the duration of the uremia is long in chronic, that can cause neuropathy. Next is band keratopathy. So band keratopathy is that where you have opacification of the cornea. That is called band keratopathy. Band keratopathy is absent in case of acute, but present in chronic. Then next is the renal bone disease. Renal bone disease, it is absent in acute, but present in chronic. And what is the renal bone disease? That is nothing but your renal osteodystrophy. And what are the conditions where you have the presence of the small kidneys? The small kidneys, the absent in case of acute, but present in case of chronic. But there are some conditions of chronic where you will have enlarged kidneys. Now, what are those exceptions? Right? Chronic renal failure with enlarged kidneys. Very important is, right, enlarged kidneys. Right? Very, very important condition is polycystic kidney disease. So polycystic kidney disease, even though there is chronic renal failure, there can be enlarged kidney. Next, in cases of multiple myeloma. Right? Next, in cases of multiple myeloma. Then infiltrative pathologies. What are those infiltrative pathologies? That is lymphoma. Then leukemia. Right? Then amyloidosis. Right? Lymphoma, leukemia, and then the amyloidosis. These are the conditions where you will have enlarged kidneys in spite of chronic renal failure. Usually in chronic renal failure, you should have small kidneys. But in these conditions, these are the differences between the acute and as well as chronic. But few more differences that you have is which group of individuals they have tolerance to azotemia. Right, tolerance to azotemia or the acidosis. Tolerance to azotemia, it is present in case of chronic, right, but absent in case of acute. Okay, so that is what is these are all the differences between the acute and as well as the chronic renal failure. These are the differences between acute and as well as the chronic renal failure. And very important is we have discussed anemia. Anemia is present in almost all the cases of chronic renal failure. So here also there is an exception, right? The exception is in polycystic kidney disease, there is no anemia, right? There is no anemia, right? Yes, Vignesh. Even in cases of diabetic nephropathy, there will be change in the size of the kidney. So I'll be discussing about the diabetes and the kidney size when I'm discussing diabetic nephropathy. But whatever you have said is correct actually. But there is difference between only diabetes and diabetic nephropathy. The size of the kidney is different. So that is the reason why I did not touch that here. Okay. Right. Then after having discussed about the differences between acute and chronic, and as well as after discussing the clinical features of the chronic, next you need to know the treatment. So workup is what? Workup is like estimation of the GFR. By estimating the GFR, you will be able to make out whether the individual is in acute or chronic. But that GFR that should be reduced for should be definitely more than 3 months. And proteinuria also. And what is the quantity of the proteinuria also? I have discussed in the beginning itself. In the starting itself, I have taught you about like how much should be the proteinuria for A1, A2 and as well as A3. Right? And in patients with chronic renal failure, let me show you some of the images. And there is one important characteristic sign that is called half and half nail sign. Even that I'll be discussing. Okay. Now you see this. This is what is nothing but your band keratopathy. Band keratopathy is that where you will have the opacification of the cornea. That urea which is increased will go and accumulate in the cornea, and that will result in band keratopathy. Next is the renal bone disease. Renal bone disease. What is this renal bone disease? That is because of your secondary hyperparathyroidism, right? Where there is the bone resorption. That will what is called renal bone disease. And I was telling you about the skin. On the skin, there will be like xerosis, ecchymosis, and then excoriation. This is how the skin will be in patients with the chronic renal failure. So out of this is your excoriations. Right, and this is ecchymosis. This is your xerosis of the skin. And this will be edema, pitting type of pedal edema. Okay. This excoriations because of decrease in the platelet function, ecchymosis because of decrease in the platelet function, and xerosis because of increase in the urea accumulation, and edema that is due to extravascular accumulation of the fluid. Right, extravascular accumulation of the fluid. Now, if you take the nails in these individuals, they have the characteristic nails, and this is what is called as half and half nail. Right, this is what is called as the half and half nail. Okay. What is that half and half nail? Half of the nail will be pale in color, and half of the nail will be red in color. That is, proximal half of the nail will be white, and distal half of the nail will be dark. Proximal half of the nail will be white, and distal half of the nail will be dark. Now, why is that the proximal half of the nail being white? The proximal half of the nail is being white because of increase in capillary density. Why there is increase in capillary density? That is because of your hypoxia. Why there is hypoxia? That is because of anemia. So because of anemia, there is hypoxia, and hypoxia is causing formation of the new blood vessels. And when there is formation of the new blood vessels, the fluid content is more here. That will enter into the extravascular compartment, and that will result in edema. And that will give you the proximal half of the nail being white in color, and distal half of the nail dark in color. And this is what is called half and half nail. And another name for this half and half nail is, this is also called as Lindsay's nail. Right? This is also called as Lindsay's nail. Okay. So the abnormality in the nail that you need to observe is, right, this is nothing but the Lindsay's nail. Okay, right. Now let me discuss the treatment in these patients. So if you see the treatment of the chronic renal failure, so how do you treat these patients? First, you need to make out what is the underlying etiology. And most of the times, what is the most common cause? We have discussed diabetes mellitus. Okay, that is the most common cause. So you have to keep HbA1c less than 7%. Right? That is a target. And how can you achieve that HbA1c value less than 7%? That is by giving insulin. You need to keep the HbA1c target value as less than 7. And what is the other comorbidity or abnormality or complication that can be observed in these patients? That is hypertension. So blood pressure should be strictly under control. And how much should be that? Less than 130 by 80 millimeters of mercury. And for this, you need to give ACE inhibitors, or the other important drug is angiotensin receptor blocker. Either of these you need to give. Okay. And only with ACE inhibitor, if the blood pressure is not getting controlled, to this ACE inhibitors, you need to add labetalol, right? Which is both alpha plus beta blocker. Okay. Next. And these patients are also having dyslipidemia. How do you treat this dyslipidemia? The dyslipidemia has to be treated by giving statins. Right? And what should be the target cholesterol levels? The LDL target, it should be less than 70 milligrams per deciliter. Right? That should be the LDL target whenever you are giving this statins. And next is vitamin D levels. How are they? Vitamin D levels here? Vitamin D levels are decreased. So because of decrease in vitamin D levels, these patients, they are having hypocalcemia, and because of which there is increase in parathormone levels. There is secondary hyperparathyroidism. So one is your vitamin D supplements should be given. And another point is you need to prevent the parathormone secretion. So what are the drugs that need to be given for preventing the release of parathormone? You need to give a drug that is cinacalcet. What is cinacalcet? Cinacalcet, it is a calci-mimetic agent. Right? Cinacalcet is a calci-mimetic agent. And this particular calci-mimetic agent, because it is mimicking your calcium, so this cinacalcet will prevent the release of parathormone, right? Your cinacalcet prevent the release of the parathormone. Okay, so that was about the medical management in the sense. And one more important point is these patients are having anemia. So what is the drug that you will be giving for treating anemia? You need to give erythropoietin supplementation. Right, erythropoietin supplementation, because these patients are having normocytic normochromic type of anemia, and this erythropoietin that you are giving, it should be through subcutaneous route, right? It should be through subcutaneous route. Blood transfusion should not be given. Only erythropoietin has to be given. Subcutaneous route. And what are these formulations? Epoetin alpha, and then darbepoetin alpha, right? Epoetin and as well as the darbepoetin alpha. Okay, so route of administration is subcutaneous, and you have to give weekly twice. This particular epoetin alpha or darbepoetin alpha should be given weekly twice. So that is about the chronic renal failure. And in the Jacob, do they need prior iron therapy? It all depends upon the type of anemia. What did I tell you? Because of uremic gastroparesis, you can see microcytic hypochromic anemia also. You can see megaloblastic anemia also. Okay, so whether to give the prior iron therapy or not, it depends upon the patient's clinical status. If at all, if because of uremic gastroparesis, because of uremia at the level of your duodenum, the iron is not absorbed, so the individual is having microcytic hypochromic anemia along with normocytic normochromic, then you give prior iron. Definitely they require. But if there is no iron deficiency anemia, the iron profile is normal, then you don't require to give the iron therapy. Okay, so it all depends upon the prior status of this individual also. Okay, right. So that is about the treatment of chronic renal failure. What is a very important part of the discussion in the chronic renal failure is about the renal replacement therapy. The next topic for the discussion. So after renal replacement therapy, I will revise the entire topic of chronic renal failure and renal replacement therapy together. So if you take the renal replacement therapy, it is in two forms, right? What are these two forms of the renal replacement therapy? One is the dialysis, right? And the other one is kidney transplantation. Right, the other one is the kidney transplantation. You take dialysis. Two forms of dialysis we have. One is hemodialysis, the other one is the peritoneal dialysis. And which group of individuals they require renal replacement therapy? when the GFR levels are grossly reduced to less than 15 in patients with chronic renal failure, they are the one who require the dialysis. Now, you take the discussion of the hemodialysis first. So if you take the hemodialysis, for doing hemodialysis for long term, I'm not talking about acute conditions. In acute renal failure also they require dialysis, but in acute renal failure when you are doing dialysis, creating the fistula is not required. But for chronic renal failure, when you are planning the dialysis for long term, there you require to create a fistula. You require to create a fistula. So in hemodialysis, I'll tell you why you should create the fistula. I will tell you the reason and mechanism also. The fistula that has to be created between the radial artery and cephalic vein, right, between the radial artery and as well as the cephalic vein. And the name of the, okay, what is the purpose of the creating the fistula? The purpose of creating the fistula is to decrease the chance of thrombophlebitis. Right, is to decrease the chances of thrombophlebitis. Why there is thrombophlebitis? Even that also I'll discuss with you. And what is the name of the fistula? What is the name of the fistula? The name of this fistula, which is created between radial artery and as well as cephalic vein, it has been given as a name in the honor of an Italian doctor. And what is the name of that Italian doctor? That is Simino Brescia fistula. Right, Simino Brescia fistula. That's the name of the fistula, Simino Brescia fistula, and which is given because he is the person who has created this fistula first, and that is the reason why it has been given in his name. That is Simino Brescia fistula. And what is the principle of the hemodialysis? The principle of the hemodialysis is facilitated diffusion. Okay, now I will show you the image. I will show you the image and I will try to explain everything now. Why you need to create a fistula, by creating the fistula, how thrombophlebitis is reduced, and what is your facilitated diffusion. All that I will discuss now. So, okay, you see this. This is what is the hemodialysis. So in the hemodialysis, what we do, we create a fistula. But remember, this hemodialysis is only for chronic renal failure, not for acute. Okay, right? Now, when you have created a fistula, but between the artery and vein, the purpose is to reduce thrombophlebitis, is what I have discussed. And what are we doing here? We are taking the blood from the vein. You see here, you have placed a tubing in the vein and you have taken the blood from the vein and you have sent that particular blood to the dialysis machine. Right, you have sent that particular blood to the dialysis machine. And here, once the blood along with impurities, right, blood along with impurities, once they enter into the dialysis machine, in the dialysis machine, you have the impurities now along with the blood. Now these impurities will get filtered. The impurities will get filtered. That solute will filter. Solute is what? It is nothing but impurity. The impurity which is there within the dialyzer machine now along with the blood, that particular impurities will filter into the dialysate. Now the blood which has been filtered, that is being taken from the dialysis machine and again it is injected into the vein, right? Again it is injected into the vein itself. So the blood is being taken from the vein and the blood is also being sent into the vein again after the dialysis. Then what is the purpose of creating the fistula then now? What is the purpose of creating the fistula now? The reason or the mechanism is that you are taking almost 4 to 5 liters of blood from the body, sending into the dialyzing machine, and again you are sending that 4 to 5 liters into the vein itself. Okay, so and how frequently you do dialysis in a week? We almost do 3 times in a week. Sometimes if the severity is more, even 4 times a week also. So this particular vein, right? So this particular vein is at increased risk of rupture because through that vein you are taking 4 to 5 liters out, and 4 to 5 liters of the blood is again coming into that particular vein. So this particular vein, it is definitely under the risk of thrombophlebitis, that is inflammation. Now, right, it is at increased risk of thrombophlebitis. So now, what is your aim? To reduce that thrombophlebitis. So how can you reduce that particular thrombophlebitis? That is by when you create a connection between artery and as well as vein. So where do we have more pressure? More pressure is in the artery than compared to that of vein. More pressure is in the artery than compared to that of vein. So when you create a fistula, the pressure in the artery, right, the pressure in the artery, it is reflected onto the venous wall, right? It is reflected onto venous wall. Once the pressure is reflected onto the venous wall, what will happen to the thickness of the vein? There will be increase in the thickness of the venous wall. Now, that particular thick venous wall, it is ready to take that large volume of the blood 3 times a week. So, the purpose of creating the fistula is to increase the thickness of the vein and to reduce the incidence of thrombophlebitis. To reduce the incidence of thrombophlebitis. That is the purpose of creating the fistula. So all of you, did you understand why are we creating the fistula? Just give me a thumbs up if you have understood the concept. Okay, so now next important in the dialysis or in the renal replacement therapy that you should understand is complications of, what do you mean by the word facilitated diffusion? Facilitated diffusion means in the dialyzing machine, you see, this is your membrane. Okay, M stands for membrane, that is semi-permeable membrane. So across the semi-permeable membrane, the fluid containing impurities, they are getting filtered from a completely impure blood to the dialysate. And this is what is called facilitated diffusion. The impurities are getting filtered there. And this is what is called as the facilitated diffusion. All right. Now, let me tell you the complications of the dialysis. So now, what is the most common complication most common complication of the dialysis is hypotension. Why there can be hypotension? Because you are taking out large quantities of the fluid, 4 to 5 liters you are taking out. Okay, and when you are taking that 4 to 5 liters into a dialyzer machine, what will happen to the fluid volume in the body? Decreases, and that will result in what is called hypotension. Okay, then what is the most common complication of what is the most common complication of recurrent hemodialysis? Most common complication of recurrent hemodialysis. Most common complication of recurrent hemodialysis, that will be accelerated atherosclerosis. I'll explain you the mechanism. Okay, why there will be accelerated atherosclerosis, I'll explain you the mechanism. And the next important complication is these patients, right? Then what are the other complications? The other complications that you will come across in these patients is they also develop dialysis dementia. Right? They also develop dialysis dementia. I'll explain you each and everything like why they're developing. They also develop CTS. What do you mean by that? Carpal tunnel syndrome. I'll explain you the mechanism why they are developing carpal tunnel syndrome. And they also develop peripheral neuropathy. Okay, which is nothing but the peripheral neuritis. And I'll explain you why they develop peripheral neuritis also. Now, let me try to discuss all these complications, why the individual is developing. So, hypotension already I have discussed why they are developing hypotension. That is because large quantity of the fluid is taken out from the body. That will result in the hypotension. And now, coming to this accelerated atherosclerosis. Why do they develop accelerated atherosclerosis? Let me try to explain to you. Now, the large quantity of, but when will you develop that atherosclerosis? When on recurrent hemodialysis, there will be development of atherosclerosis. Now, what is happening here? These patients, with every dialysis, large quantity of the fluid is coming from the tubing and it is entering into the wall, the venous wall. So, with recurrent hemodialysis, what can happen is there can be rupture of this endothelium, right? Whatever this endothelium is there, this particular endothelium can be ruptured. Once this endothelium is ruptured, why the endothelium is getting ruptured? Because with a high pressure, the blood is coming through the tubing and entering into the vessel. So there is a chance that this endothelium can get ruptured. Now, if this endothelium is ruptured, what will happen? In this area, subendothelial collagen is exposed. There is deposition of the platelets. In these platelets, there can be accumulation of the fibrin threads, resulting in atherosclerosis. Okay, so with recurrent hemodialysis, there will be development of the accelerated atherosclerosis. Now, the next point is why they will have dialysis dementia. We have why they develop dialysis dementia and why do they develop the carpal tunnel syndrome. So you take the dialysis dementia. Dialysis dementia is that there is increased accumulation of abnormal protein, that is amyloid beta 2 protein. Okay, so this increased amyloid beta 2 protein will, why there is increased amyloid beta 2 protein? First of all, the reason is that through dialysis, your amyloid beta 2 protein cannot be removed. It's an abnormal protein which is formed in chronic kidney disease. But through dialysis, this amyloid beta 2 protein cannot be removed. And this amyloid beta 2 protein, when it is not removed, this amyloid beta 2 protein, it will accumulate in the brain, resulting in what is called as dialysis dementia. Okay, same way. Now what will happen? This amyloid beta 2 protein will also accumulate in the median nerve. Right, will also accumulate in the median nerve, and that will result in the development of the carpal tunnel syndrome. Okay, next. Now, why there will be peripheral neuritis? Why there will be peripheral neuritis is because during dialysis, there will be loss of vitamin B5 through that membrane, through that semi-permeable membrane. That B5 gets filtered and gets excreted out. What is your B5? Right, that is pantothenic acid. So once the pantothenic acid is out, the individual will develop what is called peripheral neuritis, which is nothing but your burning feet syndrome. Okay, so that is about the complications related to your dialysis, right? So whatever we have discussed is like the hemodialysis. Now let me take up the discussion of the peritoneal dialysis. Now in the peritoneal dialysis, right, in the peritoneal dialysis, the peritoneum will be acting as the artificial membrane. Right, the peritoneum will be acting as the artificial membrane, right? And on the peritoneum, you have the peritoneal vessels. On the peritoneum, you have the peritoneal vessels, right? And the peritoneal vessels contain the impurities, right? Because in chronic renal failure, you have that impurity. You are having that impurities. That impurities which are there in the peritoneal vessels, which are present on the surface of the peritoneum, they are being filtered. How are they being filtered? Like a fluid is sent into the peritoneum, right? A fluid, that is peritoneal fluid, is sent into the peritoneum. And this particular peritoneal fluid, it contains the dextrose. It's a dextrose dialysate. Right? It is the dextrose dialysate. And this peritoneal membrane containing peritoneal blood vessels containing impurities, now they will start filtering the impurities. Now they will start filtering the impurities into the peritoneal cavity. They will start filtering the impurities from the peritoneal blood vessels into the peritoneal cavity. Thereby, now the dextrose dialysate, it is containing impurities, and that is being taken out and then discarded. This is what is your peritoneal dialysis. Whereas in hemodialysis, you have a separate artificial semi-permeable membrane. But whereas in peritoneal dialysis, the peritoneum itself will be acting as the artificial membrane. Okay. So I'll just write some differences between the hemodialysis, then the peritoneal dialysis. The points are the rate at which the dialysis occur. The hemodialysis, it occur at faster rate, and the peritoneal dialysis, it occurs at a slow rate. Okay. Then the peritoneal dialysis, it is a very easy process. it can be done even at the home, but hemodialysis, that should be done only in the hospital setup, right? And solute removal in both of them, that is across the concentration gradient. Right, that is across the concentration gradient in both of them. And if you take the membrane in hemodialysis, you have semi-permeable artificial membrane. Right, whereas in peritoneal dialysis, the peritoneum itself will be acting as artificial membrane. And the method, if you see, in case of the hemodialysis, line from the vessel, okay, line from the vessel, it is connected to artificial kidney. Whereas in case of peritoneal dialysis, the indwelling catheter right, it is placed in the peritoneal cavity. Right, placed in the peritoneal cavity. That is about the differences between peritoneal dialysis and as well as the hemodialysis. And in the peritoneal dialysis, what did we discuss? The dialysate is dextrose containing dialysate. Okay. So these are differences between your peritoneal and hemodialysis. And what are the methods of renal replacement therapy? One is dialysis, right, which we have finished. Then next is the renal transplantation or the kidney transplantation. Right, so you take the kidney transplantation. Which form of kidney transplantation should be done? Yeah, Kamal Nathan. The complication of peritoneal dialysis that can be seen is spontaneous bacterial peritonitis, SBP. Right? Peritonitis. That would be, it need not be spontaneous bacterial peritonitis, but peritonitis is the complication. Okay? Next. Then followed by that, you need to know about the kidney transplantation. So kidney transplantation, if you see, which form of the kidney transplantation has to be done? It is allogenic kidney transplantation, which is being preferred. And what do you mean by the word allogenic? Allogenic means the kidney taken from first degree relative. Right? That is what is called allogenic kidney transplantation. And whenever you're doing kidney transplantation, definitely you need to do HLA matching, and at the same time, you also need to do blood grouping. Right, HLA matching and blood grouping has to be done. And you take this HLA matching to check for where is the gene for the HLA matching located. The gene for HLA matching is located on chromosome number 6. Okay. And for blood grouping, so for blood grouping, where is the gene located? The gene for blood grouping, it is located on chromosome 9. So blood grouping and HLA matching, both of them has to be done. Then followed by that, you need to do certain tests for the donor and you need to do certain tests for the recipient as well. So now, what is the workup that has to be done for the donor and workup that has to be done for, so the transplantation is very, very important. That is allogenic kidney transplantation should be done. Okay. So if you take the workup, what is the workup that you do in the donor and what is the workup that you will plan for recipient? The workup that you need to do in the donor is the transmissible viral infections, that is HIV, hepatitis B virus, then the hepatitis C virus and cytomegalovirus. These are the viruses which can be transmitted through the transplants. That is the reason why you have to do the testing for the donor. And you take the recipient. What the recipient has to undergo? Recipient has to undergo Doppler studies. Why Doppler studies? Okay, that is mainly to rule out renal artery stenosis. We need to do Doppler within the recipient, or not only renal artery stenosis, even if there is any other vascular malformations, that can be done, and that can be tested by your Doppler. Now, which particular kidney of the donor has to be taken? The left kidney of the donor has to be taken, right? Left kidney of the donor has to be removed. Okay. Now, why is that left kidney of the donor has to be taken? That is because, just 1 minute. Right. So, why is that you need to take the left kidney of the donor? That is because the left kidney has longer renal vein. Left kidney has the longer renal vein. So, left renal vein is longer. Right. Now, after taking the left kidney from the donor, where you have to place it? You have to place it in the right iliac fossa of the recipient. You have to place it in the right iliac fossa of the recipient. Okay. Why is that you need to place in the right iliac fossa? We don't place it in the loin area. We place it in the right iliac fossa. Why is that we place in the right iliac fossa? I'll show you one of the image. Okay, you see this image. So, I think I have this there also. 1 minute. Okay. So, we don't place it in the loin area. We place it in the right iliac fossa. And we connect that to the aorta and as well as the iliac veins. I'll take this to the notability. 1 minute. You see this. So, again, we don't place it here because already there are a lot of connections and all. So, we will not try to disturb that. Okay. So, what we will do here, we will place it in the right iliac fossa and we will connect the kidney to the iliac vessels. Right. So that is how. And why don't we place it on the left side? Because in the left iliac fossa, you have the important structures like the ileum. Sorry, you have the rectum, right? And you have the sigmoid colon, like which will be passing down. And when you place the kidney on the left iliac fossa, there is chance that the kidney can compress these structures. That is the reason why we avoid keeping in the left iliac fossa. We place it in the right iliac fossa. So this is what is your kidney transplantation. But once the kidney is transplanted, do you think that the recipient immune system will keep quiet? No. Immune system will start the immune hyperreactivity. So secondly to that, what we need to do, we will discuss now. Okay. So you just take a break now, right? You just take a break for 10 or 15 minutes. We will come back and discuss like how to prevent the rejection. Because once you place that in the right iliac fossa, immediately there is chance of rejection. So how will you prevent that rejection and all? We will discuss once we come back from the break. Okay. So just take a break for 10 or 15 minutes. We'll be back now.